Thank you very much, Larry, and thank you for the chance to join you here this morning. I'm so excited to hear the stories of the progress being made in your segment of our industry. You could not be more important to the future of the Centers for Medicare and Medicaid Services and for the well-being of the publics that I serve. I thought I would take the few minutes I have with you first to thank you for your work, but also to give you a little bit of a sense of the scene here in Washington, what's happening in the world that I'm working in at the moment in the Centers for Medicare and Medicaid Services in a very interesting time of evolution of our American healthcare system. I don't have to tell you that it's a polarized time. It's a time of enormous contention and debate. Here in Washington, there's lots of disagreement, and you read about that all the time. We're trying to make healthcare better, but people have different ideas about how to accomplish that. But one thing everybody does agree on, and that is that the problem of healthcare cost is center stage. Healthcare costs now are linked to the economic vitality of our country, which is linked to the well-being of the economy of the world. And this is not just a public sector issue. It's not just about government and federal debt and federal deficit and states' burdens, but also the private sector. We are in a very difficult moment in healthcare in which our attentions are drawn to cost. In my opinion, underneath that concern about healthcare's fair share of the economy, there is a choice. It's a choice less clearly recognized than I wish it were, and one about which I'm speaking often now. Here's a basic outline. In an effort to arrive at a healthcare system that's sustainable for our country with respect to the costs of care, we really have two choices. One way, one choice, one option is it's easier, it's seductively easier. It's to cut care, it's to withhold things, take things away from people, reduce benefits, shift burdens, cut payments. This approach, when you have trouble with money, is familiar to you. It's what you do in your homes when times are rough. They have advantages. They're swift. The payer, Medicare, private payer, can just change what they do. It doesn't ask for any change on the delivery side. The results are relatively certain. You just get the money back when you cut. It's contentious. You have to fight about it, but it's one way to solve the problem, at least in the short run. My premise, not just in my current role, but for 30 years of work on healthcare before I arrived at CMS, is that it's not the best way at all. It's the wrong way. If there's another alternative, and there is an alternative, and that's what I want to talk with you about. The alternative is to improve care, improve things. You can understand that. The computer you use today, most of the products and services you rely on, are today functioning at a level far higher than they were even 5, let alone 10 years ago. The computer you work with today has functionalities that it weren't imagined 5 years ago, and it's less costly than it was. And that's because the way it's made has changed. Over time, in order to survive in a globally competitive environment, people that make things that serve you have had to figure out ways continually to make them better and better at lower and lower cost. Improvement and cost reduction go together in many, many sectors of our economy, and so can they in healthcare. That, I think, is the other choice, the other possibility, the one I favor, which is to improve our way out of the cost dilemma. That's been my hope and my drive for decades, and it's certainly what I feel here at CMS. And indeed, within CMS, I'm urging that we consider ourselves not just a payer, maybe not even mainly a payer, but part of a solution to the American healthcare dilemma through the leadership of improvement. The vision statement at CMS today, since I arrived, reads as follows: we will be a major force and a trustworthy partner for the continual improvement of health and health care for all Americans. A major force, proactive, a partner, that means a partner with you, for the continual improvement. We're never done. This is an ongoing journey of health and health care for all Americans. That's our vision statement. That's a statement about change. It implies a need for change because embedded in that notion is that the healthcare system as currently configured, the way it works in your segment of the industry and in all segments, is not up to the task. It isn't capable. We haven't inherited a healthcare delivery system capable of giving the public, society, ourselves, our loved ones, what we want and need. What we want and need, we refer to in CMS now as the three-part aim. You're familiar with it. It's three goals at once. Better care for individuals when they're sick or in your hands. Better health, reducing the need for health care because people stay healthier longer. And lower cost through improvement. Not lower cost by withholding, not lower cost by cutting, but lower cost through improvement. Better care, better health, and lower cost. That represents the measure of success, in my view, for CMS, for any payer, for any participant, any steward in the healthcare system. Better care, better health, and lower cost through improvement. That's the name of our mission. Now, we're underway. In our country, we have now an enormous resource available to us that wasn't there 2 years ago. That's the Affordable Care Act, the new law, the legislation passed a year ago March, that puts at our country's disposal a series of improvements which, if we are willing to grasp and work with, can get us, I think, to the three-part aim. The Affordable Care Act is actually not really one law, it's two laws. That's how I think of it. One part of the Affordable Care Act, Law 1, it's a coverage law. It's a law about justice in America. It's a law about security. It's a law that says, Americans, we want you not to lose sleep at night because you can't find health care coverage or may lose it if you get sick. And so there are a whole bunch of elements in the Affordable Care Act that give our public what they want and what they need, which is the security that they can have health care when they need it. When we're done, 32 million Americans will have health care coverage through expansion of Medicaid, through premium tax credits and support in the exchanges that they otherwise would not have been able to find. People will no longer have their health care insurance taken away when they get sick by rescission, which no longer will be allowed in 2014. Insurance companies will be required to issue policies even if you have a pre-existing condition. Kids under the age of 26, like my own youngest daughter, can be covered under their parents' policies. And elders, the people you're most concerned about, will have better coverage for their prescription drugs as the donut hole closes, much more prevention benefits, so that they can stay well and healthy as long as possible. All of that is important. It's a majestic step for our country to try to provide health care coverage really as a human right. And we're headed in that direction. I'm very proud to be part of that story. The problem is, and you deserve credit for that also. The support you've given to that progress, that commitment in our country matters a ton, and I'm very grateful for that, as are all the citizens who will benefit. The problem is, it's not sustainable. The healthcare system, as I said to you, isn't built for the level of excellence that we need in order to be able to promise ourselves and our children and their children that they will have the justice and the access that we want to provide. That's evident now in many dimensions of care. The dimensions of care include problems in acute care. We know that care is unsafe. There's harm in care. Harm is pervasive in care, not because of ill will or bad intention or incompetence on the part of the healthcare workforce. People really who give care, the nurses, the doctors, the pharmacists, the therapists, the managers, they want to give good care, but they know, if they look clearly, that the care fails. We have data from our own Inspector General in studying Medicare patients that as many as 1 out of 6 or 1 out of 7 in hospitals are injured by the care that they receive in hospitals. We have a very important report in Health Affairs, the journal just 6 months ago, showing some injury to patients in hospitals 1 out of 3 times. 1 out of 3 admissions a patient is injured in care. And we've seen all over the country evidence of these kinds of defects in the patients you care for. Pressure ulcers that can be prevented but occur anyway. Infections and complications in care, post-operative complications, pulmonary emboli, and urinary tract infections. The good news is that we know how to eliminate them, that many of the forms of injury in care have the consequence both of hurting the patient and the family, but also raising costs. And for almost every form of injury, we know some place that has minimized it, in some case eliminated it. Central line infections, catheter-associated urinary tract infections, pressure ulcers, 95%, 98%, 100% elimination. Bringing excellence to scale is an important agenda. and will make healthcare more sustainable in the long run. The Partnership for Patients, which Secretary Sebelius and I launched almost a year ago now, is intending to help reduce healthcare complications in hospitals around the country by 40% in 3 years, a massive goal well underway, supported by the Affordable Care Act, because that is funded through the Innovation Center and other elements in the Affordable Care Act to support better care when you're sick. Seamless care, a second area of improvement. We have, for example, 9.2 million dual eligible patients in the country, people who are eligible for Medicare and Medicaid. They all need coordinated care in programs like PACE and others, where we know what to do for people who have multiple chronic illnesses, problems with behavioral health, poverty and other burdens in their lives. When their care becomes coordinated, their well-being improves, their rates of use of acute care services goes down, costs fall, and their lives improve. We know how to do that, and yet we haven't had a system which supports integrated, coordinated care. Now we do. In the Affordable Care Act, we have a whole set of tools now that will allow us to better coordinate care. Accountable care organizations, bundled payment, medical homes, health homes, community-based care transitions, programs with which you and your colleagues are hopefully increasingly familiar and able to take advantage of to craft seamless journeys for patients. When journeys for patients become seamless, costs fall and patient well-being rises. Better care through improvement. And then there's prevention, reaching upstream to help keep people well. New investments in the Affordable Care Act in prevention benefits for elders, in tobacco and smoking cessation programs. The 1 Million Hearts campaign, just launched a few weeks ago by CDC, Centers for Disease Control head Tom Frieden, Secretary Sebelius, and me, aiming to encourage a very simple set of interventions throughout our population, the ABCs, aspirin, blood pressure control, cholesterol control, and smoking cessation, which together can eliminate 1 million heart attacks and strokes over the next 5 years in our country with the simplest possible clinical and community-based interventions. The Affordable Care Act brings us that opportunity through support to prevention programs, benefits, and others. All told, we have in our hands a chance now to change care for the better care, better health, and lower costs through improvement. But unlike cutting, unlike reducing payments or taking away benefits or just making things, paying people less or shifting burdens, unlike those direct ways to save money, this agenda, the important agenda, the possible agenda, the improvement agenda, is inevitably one of partnership. It cannot be done certainly by government alone, or I would say by any stakeholder alone. You are essential. The concept of partnership now has to undertake real new meaning in which we commit together as care providers, as funders of care, as citizens and users of care, as professionals across the community, as institutions. We commit together to achieving the sustainable healthcare system that our country can benefit from. Better care, better health, and lower costs through improvement. In some sense, the target will be waste. It'll be the myriad forms in which, through no one's really bad intention, but just through historical accident, the legacy fragmentation of our system, the lack of modernization of technologies and information, the training of a workforce for silos instead of for cooperation, and payment systems that encourage fragments. Because of these legacies, we have embedded within the healthcare system enormous layers of waste, things that add no value to patients and families and that cost us without benefit. In some ways, a modern approach to the improvement of products and services, including healthcare, is a focus on non-value-added activities so that we can reinvest recovered resources at a time when resources are very constrained in the well-being of the people who depend on us. Waste takes many forms in the healthcare system. I've already told you about some failures in care, like those pressure ulcers and central line infections and falls and post-operative complications. These erode opportunity. They are forms of waste which can now be eliminated. Ascension Health, reducing pressure ulcers by 95% throughout their system. Hospitals in our country that have eliminated central line infections, falls reduced by 50 or 60% or more. One form of waste is failures in execution of care. Another is failures of coordination of care. When that patient goes home from the hospital without adequate supports at home and bounces back in the hospital with their renewed congestive heart failure or complications of their stroke, their costs rise, the quality of care falls, their well-being falls. That's a form of waste, failure of coordination. Now we have the opportunity to invest in remedy for that form of waste. A third form of waste is overtreatment, overuse of things that absolutely cannot help someone. A surgery, an image, a medication, a visit, which add no value at all to the patient. They're there because of habit. They're legacies of a fragmented fee-for-service system in which we have simply paid for volume instead of for value, in which we have asked the question not how well do you do, but how much do you do. That system of payment, that system of encouragement is coming to a close thanks to the Affordable Care Act and to progressive work in the private sector as well, in which now we can begin to reward and encourage and support providers of care who want to focus on the question, how well does the patient do, not how much activity do I engage in. Overtreatment, a major source of waste in our system. Another is administrative burdens. We in government stand to blame, to take a lot of the blame here. This is the legacy of rules that no longer have purpose, irrational variation in procedures for certification and accreditation, conditions of participation, measurement that doesn't make any sense at all. Under the presidential directive now, presidential order about 8 months ago, every department in government, including HHS, including CMS, is directed to root out unnecessary forms of administrative burden that we are foisting on patients and families and you with no value whatsoever. And you will be seeing more and more investment in that idea of streamlining and sleekening the necessary forms of surveillance and accountability that we as good public stewards need to exercise. Administrative costs are another form of waste. So are excessive healthcare prices, prices that make no sense, prices that do not reflect the costs of production, that are there because of anomalies in the way the pricing schemes move. You can see what happens when rational pricing begins to enter a system in our durable medical equipment competitive bidding scheme. Ordered by Congress, we have DME competitive bidding now in 9 areas tested for 9 products, a 32% reduction in cost and almost no complaints whatsoever emerging from the markets, from the patients, or even the suppliers. A much better system, much more rational pricing because we're letting normal market forces occur. And then lastly, a form of waste that I've learned a lot about since I arrived, fraud and abuse. I thought it was a kind of rounding error problem in our industry. It's not. Healthcare fraud and abuse is very widespread, not among many, many providers of care, but few sufficiently aggressive that we cannot tolerate it. We cannot stand aside as patients and families and the public treasury and other insurers are ripped off by criminal elements and others who really intend to steal the money. That will stop. The Affordable Care Act has put in our hands new and important tools for ending fraud and abuse, heat strike forces now in 9 cities in our country, predictive analytics that allow us to look at patterns of use and spot anomalies, and provider registration that is now much more disciplined, especially for people who are in very high-risk sectors. Better care, better health, and lower costs through improvement. This is achieved by working together to make sure that every step we take, every single deed we engage in is patient-centered, oriented around the true needs and the true value for patients and families and the vulnerable people who depend on us. Can we do this? Can we arrive at a healthcare system through improvement that is sustainable, patient-centered, safe, efficient, equitable, timely, one that really serves the needs of the public, one worth every dollar we spend on it, and full of the kinds of innovation and creativity and imagination that actually allow us to do better and better every day for the people we serve? Yes, we can. We can do this, but we can only do it together, and that is why I'm so pleased to have this chance to spend some time with you this morning. There is a challenge before us to recraft a healthcare system able to meet the needs of the publics we serve at a price we can afford with no compromise whatsoever in the quality and service we offer to the people who depend on us. I know that's where your hearts are. I know that's why you go to work every day to achieve that, and I assure you that CMS is very much on your side. We want to do this together with you and reinvent healthcare systems to achieve what we can for our country and what our people need and want: better care, better health, and lower costs through improvement. Thank you very much. Thanks a lot.
Thank you. I just have one comment in Wes. Thanks. Dr. Berwick, you'll find the agenda of LeadingAge in our leadership imperatives right in line with your triple aim. We call it resident-centered care, innovative community, and better use of our stewardship responsibility. Thank you for your disciplined leadership in all of this, and we will do our part to make sure those that are vulnerable have a better quality of life at less cost, and keep up your good work. Thank you. Yeah.